Sure.
But I think that you're making a deep assumption, which is, I think, erroneous. That is, there's a guru, he has answers to all these questions, and he can do so by some wise, brief formulations like the great philosophers, Plato or Aristotle. Life is not that. Telling a story is already not an aphorism. It is inviting somebody to share an experience.
So, can we just start with the experience that is intriguing, the one of Samuel Levine,
sure.
and just begin there with
I think that
its relevance to patient safety and the invisible, being able to notice something, to be alert to the flaws in the system that need to be corrected. Just recall the story.
No problem. Is the camera
Yeah.
on? Oh, okay.
Yeah.
The meeting with Levine was a formative experience that transformed me totally. And it began with my great faith in pharmacology, that was going to revolutionize medicine, assuage all discomforts, but also improve cardiovascular function, lower hypertension, control diabetes, a pill for weight, a pill for impotence, a pill for boldness, you name it. And in first rounds with Levine, which would have been July 1st, 1950, nearly 60 years ago, we came to a patient and the intern was presenting, and he enumerated 12 drugs that the patient was getting. And Levine said, "Stop all but 2," and walked away. And the intern came charging after him and said, "Dr. Levine, which 2?" Levine's laconic response was, "Any 2. Stop any 2 drugs." And to me that was paralyzing intellectual experience, because it meant really, it didn't matter. These drugs were not as important as I imagined. And he understood it because he could not possibly conceive the interaction of 12 drugs. Neither could God. So that was a first startling reaction. The next really had to do with the chair treatment of cardiovascular disease, which I am reflecting, what was the greatest contribution that I participated in terms of life saved. It's not a defibrillator, it's not coronary care, it's none of those. It was the chair. And the reason being is that it led to a concatenation of unintended consequences that changed the whole course of cardiovascular care. And Levine began in a very sort of mechanistic way. He was called in consultation to see a patient in Washington, and the patient was lying in bed and gurgling pulmonary edema. And he was so short of breath, and he was in an oxygen tent at the time. It was quite uncomfortable, and he wasn't getting better. And Levine saw him lying flat, and he says, if he sat up in a chair, gravity would pull the fluid from his lung to his feet. It would be unsightly edema, but not life-threatening, sort of effusion in his lungs, suffocating the oxygen flow. He got him out in a chair, and within an hour, the patient was breathing better. It seemed like a miracle. And Levine said to them, keep him out in a chair for 24 hours. That was unheard of. A sick patient belonged in bed. That was the mental construct. And next day, he was nearly improved. So Levine had this thought that coronary patients, because many of them were threatened with heart failure, and since congestion of the lungs would impair healing of the heart craving for oxygen, why not sit the patient up? My approach was vastly different because I was focused on the patient as a human being, and I saw what was happening to people, how they were involuting with bedrest to become infantilized, and more than that, become profoundly psychologically depressed, lose a total will to live, weren't permitted to move, had to have a nurse shift them on a bedpan, uncomfortable, itchy, and miserable. And the concept was, if you're in bed, you're going to die. If you're in a chair, you can die in a chair. You have to be brought back to bed. So to me that was very appealing, and the congestive heart failure made no sense. How would getting a patient out in a chair for 20 minutes work for 24 hours in terms of this fluid dynamic that he was speaking about? He was not readily swayed, neither was I. I was as pig-headed as he was. So the long and the short of it, we began to get people out in a chair. It taught me another lesson. It taught me the power of even wrong traditions, bad tradition, dysfunctional tradition, how the house staff resisted it. They fought tooth and nail. They had no vested interest one way or another, but the culture was, chair is dangerous. Chair means more cardiac work. You want to rest the heart. You can't put a splint on the heart. You can't immobilize the heart, so you reduce the amount of activity. Bed rest. But bed rest regards as a dead body. A living body lying there, agitated, has more activity of the heart than a sedentary person comfortable in a chair. And once we began, a whole host of things happened. One, pulmonary embolism that killed 30% of heart patients at the time disappeared. And the invention of anticoagulants came as a response to bed rest of the patient had a heart attack. Because everybody recognized the enormous toll. That came in 1948. My work was 1950. And I got him out of bed, and I wrote the first paper. Levine says, Bernie, bring in a paper on Monday. This was Friday. I never wrote a paper in my life. And so I sweated. I was totally up, 2 days and 2 nights, and wrote the paper and presented Levine, and scared out of my wits that he'll criticize the bombast, the improper prose, the non-use of scientific language. I was a neophyte. And I didn't hear a word from him. Monday, Tuesday, Wednesday, Thursday, Friday. By Saturday, I was really agitated. And I said, Dr. Levine, did you read the paper? He said, I didn't only read it, I mailed it off. And that was published. That paper, written, never changed a word, published in the JAMA and also Transactions of American Association.
So that's an example of being able to see a flaw in the system of the healthcare that was being given. Also, you touch upon the inability of the other clinicians to be able to see that, and they resisted, even your early results, they resisted change.
But they resisted change for reasons that are not totally clear to me to this day. Because if any doctor is tuned to the well-being of his patient and exercises a modicum of common sense, if you are lying in bed and you wake up, and after a while you grow very uncomfortable, you move out of bed. Why don't you imagine the same for the patient who's lying in bed with all the psychological implications? What happened thereafter was various syndromes associated with bed rest. Frozen shoulders were a terrible thing. Intractable constipation, that was such a challenge, where you can't have a bowel movement and you have to disimpact feces. I mean, you can't imagine the nightmare of what happened from bed rest and psychological breakdowns. And furthermore, you get a patient out of bed after 3 weeks, okay? You'd sit him up in a chair and you'd take their blood pressure. Their blood pressure would collapse. So back to bed. He's not ready. So how many times I get a patient out of bed and his blood pressure got dizzy? Okay, back to bed. A vicious cycle. That disappeared. Then the patient themselves compelled, what am I doing here? I'm feeling so good. And it shortened hospitalization from 4 weeks to 3 weeks to 2 weeks to 1 week to 3 days. And the life saves are millions of lives, just getting a person in a chair. Now the question you pose is, why did they oppose it? And my answer is several reasons. Firstly, the power of tradition. We are all imprisoned by traditions. And the little child sees the emperor nude. You know, we don't ever see the emperor nude. The emperor may stand totally without underwear. You will not see it. I don't care how good your vision is, if tradition has captured you. Secondly, there was a logical explanation that heart, any organ that is injured, has to be arrested. A broken bone is splintered. A kidney that malfunctions, you lower the protein intake. What do you do for a heart? So that was a logical, but wrong scientifically question to pose. There was another element, I think. The doctor made an enormous income. When a patient, if you had 10 patients in the hospital with heart attacks, they'd come in and say good morning, look at the chart, take an EKG, and have a look at it. And somebody would take it, the technician, he'd say, oh, another week in bed, you know. And for every day in bed, the patient paid you $10 or whatever. So if you had 10 patients, 4 weeks, this didn't work, but in some subtle way. Subliminally, right. Because what is interesting to me, there isn't a thing in medicine that you can't find some research on. Green eyes versus blue eyes, central baldness versus temporal baldness. You name it, there is literature on it. There's not a single paper on bed rest. Why? Why wouldn't somebody ask the question, how long bed rest should be? Or how should bed rest? Should there be pillows? Should there not? Should you elevate the legs to increase flow of blood so you prevent phlebitis? To use elastic stockings? Nothing. Why? Why?
Is it because there was too much emphasis on theory and not enough skepticism, not enough self-questioning?
All those, yes, all those. But at the same time, doctors question everything. You know, they are skeptics, they don't believe this. But the moment something is cloaked with the word scientific, and I have a scientific explanation that embraces some physiologic principle or biochemical principle, it becomes exempt from criticism by the majority of doctors. Certainly there'll be researchers who will pose questions and search, but here it was. And to me, this was a powerful lesson, and it made me very if I was of a different nature, I would have become very cynical.
But you maintained optimism and became motivated to question.
I became motivated to question nearly everything. Everything. I accepted nothing. I would go through and they'd say, oh, this is so-and-so. Who says? And what does it matter who says? What are the facts beyond what who says, you know? And this was very helpful for me, because I then forged into fields that I had no right to be. I once met, it was very funny, I once met with Dr. Koevenhoven. Koevenhoven is the one who introduced cardiopulmonary resuscitation, you know, pressing on the chest. Now, he was an engineer, and he retired from engineering, and he was going crazy. So he went into Johns Hopkins and he says, would you permit me to hang around the emergency room? And this old man, I said, sure. And he immediately saw people arriving dead, and he says, hey, he had developed at the time the first defibrillator, the alternating current defibrillator, which was a menace, I thought. But nonetheless, he had it. But how do you keep the patient alive till that? So he had the idea of pressing on the chest, you'll get a little blood flow to the head. He, an engineer who had nothing to do with body, anatomy, pathology, cardiology, he comes to give a lecture at MIT, distinguished lecture. And he's fascinated. Here a cardiologist introduces a major advance and abandons his alternating current, introduces the DC type of defibrillator that is there still. So he invites me for lunch. And we start talking. He wants to know the principles, the electronic arrangements. I don't know a volt from an ampere. And he says, oh my God, man, you're stupid. I mean, he burst out, you don't know a damn thing about electricity. How could you have developed that? And I said, so I asked him a question about the heart. I said, my God, you're stupid. You don't know a thing about cardiology. How could you have invented cardiopulmonary resuscitation? He burst out laughing. He was bright enough to realize that it takes an outsider frequently, who just is out of the box and comes, like a little kid is so bright, right? Why? Because the little kid asks you questions that you as an adult don't dare.
So that's one of the most important principles of patient safety, is that the teams of professionals collaborating and also the patients themselves become part of making the system safer, because they can see from a different angle with a different background. It seems that at that time there was perhaps not enough of that, and can you comment briefly on the challenge of the clinician feeling responsible for all of the patients that they've treated by that method, and now kind of confronting their past practice and having to question it, just like it must be just like the occasional medical error. It's intensely difficult for health professionals to grapple with.
And it is, and as a matter of fact, it is as though the past never was there. It never happened. The bedrest period never existed. That to me is fascinating. Sociologic phenomenon. They're not doctors who are reflecting what led to bedrest, that it lasted for 30 years, you know. Heart attacks were first recognized in 1918, 1919, and this is 1950, and we introduced it in 52, so here's 32 years of practice. No discussion.
And so being able to reflect on your errors and study them and learn from them is a key to making progress.
I think that the one cultural aspect of medical school that has been ignored is trying to make a virtue of error recognition, of every day having a period where you sit down and reflect on what errors were committed that day and why and how. And so when I used to conduct rounds in the morning, the first thing I'd say, bring the drug book. We had a book of drugs where you wrote in the orders and what the nurses did when they fulfilled the orders. Instead of reporting from the intern, oh yeah, we ordered this and this, no, let's look at the book of action and transaction. And they thought that was odd. I mean, these are nurses, you know, so lesser at that time participants in the medical experience. And we go, oh, but there wasn't a day that there wasn't some errors, mostly minor, but sometimes very major. The wrong drug, the wrong dose, not given at the right time, endlessly. And after a while, the house staff wanted to look at that, because that was a corrective that was going on. And I found that the young doctors especially were afraid to admit error, because to admit error, they thought they'll prove themselves not being bright, not being responsible, not being engaged, and would not advance. You have to bristle with brightness and self-importance and self-assurance. You know, the moment you are self-assured, you immediately persuade others that you know what you're doing. And that itself was struggled. I mean, many doctors whom I respected would be loath to admit error, and that becomes a punishment for doctor. Malpractice wouldn't happen at the extent it's happening. Malpractice litigation, I mean, would not happen if doctors admitted errors and say, I made a mistake, here's what happened, here's what transpired. And the patient, I had a patient, this is the last story because I gotta go.
Well, can we move to just finish with talking about the need for maintaining this kind of quest of compassion in medicine and the idealism of medical school students?
Malcolm, I would say if you could persuade medical students to read two books, The Lost Art of Healing, and one that is very political, and that is Prescription for Survival, because Prescription for Survival deals with a profound principle in medicine that nobody knows about, the Virchow principle. Virchow, look him up, Rudolf Virchow, the greatest practitioner of medicine of the 19th century. And he really laid down the rules, the laws of engagement beyond the bedside, the epidemiology and the science, and profound thinker. And he wrote 2,000 papers, and there's nothing in medicine he didn't touch, from thrombosis, blood clotting, subacute bacterial endocarditis, heart disease, you name it, Virchow was there. And he introduced sanitation to Berlin. He changed healthcare in a profound way. And he is my role model. So, and I think the book, Prescription for Survival, brings in doctor activism, where doctor activism has to play an important role in saving this planet. And without it, one important part of the front will be lacking.
And that is, so social responsibility, you would say, is a key medical competency that...
Absolutely. I gotta go. And you owe me an outline.
Yeah, I'll do that. I needed to...
And I need some questions. You have 2 copies, 1 copy, so I can think on those questions.
Thank you.